Welcome to Urinary Casts and Crystals, a visual guide to diagnosing kidney disease at the microscopic level. This educational presentation, led by Dr. Adetiloye, is for educational purposes only. Urine casts and crystals are like diagnostic fingerprints, small but significant. These tiny structures can reveal a lot about kidney health. A red blood cell cast? That could mean glomerulonephritis. Envelope-shaped calcium oxalate crystals. They hint at kidney stones or ethylene glycol poisoning. In this presentation, we'll decode these urinary findings together. Urinary casts are cylindrical structures formed in renal tubules, composed of tam-horsfall protein and cellular elements. Their presence localize pathology to the kidney, rather than lower urinary tract. Urine crystals are solid particles from dissolved minerals, indicating metabolic issues or infections. Microscopic examination is essential for detection. Let's now explore a more in-depth analysis, beginning with urinary casts. Hyaline casts are clear, colorless, and translucent, containing only tam-horsfall protein. They are seen in dehydration, exercise, fever, prerenal azotemia, and may be normal in small amounts. Hyaline casts are the only type that can be considered normal under certain conditions. Red blood cell (RBC) casts are hallmark findings of glomerular injury and are definitive evidence of intrarenal bleeding. They appear as cylindrical structures containing intact or lysed red blood cells embedded within a proteinaceous matrix, typically brownish or reddish in color. Their presence on urine microscopy strongly suggests glomerulonephritis, distinguishing a glomerular source of hematuria from other urinary tract causes. Dysmorphic RBCs often accompany RBC casts, indicating glomerular basement membrane disruption. A useful mnemonic to recall the primary diseases associated with RBC casts is PALE-GRM, which includes post-streptococcal glomerulonephritis, Alport syndrome, IgA nephropathy, lupus nephritis, Goodpasture's syndrome, rapidly progressive glomerulonephritis, and membranoproliferative glomerulonephritis. These conditions represent various etiologies of nephritic syndrome and typically present with hematuria, hypertension, and varying degrees of renal impairment. RBC casts are pathognomonic for glomerulonephritis and should prompt immediate evaluation for underlying systemic or primary renal disease. White blood cell casts contain neutrophils or lymphocytes, suggesting intrarenal inflammation. They are seen in conditions like pyelonephritis and interstitial nephritis, indicating a renal source of infection or inflammation. WBC casts are key in distinguishing upper tract infections from lower UTIs. Epithelial cell casts indicate significant damage to the tubular epithelium and are most classically associated with acute tubular necrosis, particularly due to ischemic insults like hypotension, shock, or nephrotoxic agents such as aminoglycosides, radiocontrast media, amphotericin B, and cisplatin. They may also be seen in acute interstitial nephritis, where tubular injury is secondary to hypersensitivity reactions to medications like NSAIDs, penicillins, or proton pump inhibitors, or due to systemic infections or autoimmune conditions. Additionally, viral infections, especially cytomegalovirus and polyomavirus in immunocompromised patients, can cause direct epithelial injury and lead to cast formation. Heavy metal toxicity, such as from lead or mercury, is another recognized cause. Under the microscope, these casts appear as a matrix containing one or more epithelial cells, which may retain their round nuclei or show signs of degeneration. Granular casts have a coarse or fine granule appearance, representing degenerated cell debris. They are associated with acute tubular necrosis and chronic kidney disease. Muddy brown casts, a type of granular cast, are strongly associated with acute tubular necrosis. Fatty casts contain fat droplets and appear as a Maltese cross under polarized light, indicating lipiduria. Fatty casts are pathognomonic for nephrotic syndrome, reflecting significant proteinuria and lipiduria due to loss of the glomerular filtration barrier. These casts form as lipids are reabsorbed by injured tubular epithelial cells, which then slough into the tubular lumen. To recall the major causes of nephrotic syndrome associated with fatty casts, the mnemonic DAM-MFL is used. Diabetic nephropathy, the most common cause in adults; amyloidosis, minimal change disease, common in children; membranous nephropathy, associated with autoimmunity or malignancy; membranoproliferative glomerulonephritis, focal segmental glomerulosclerosis, and lupus nephritis, specifically Class 5, the membranous form. Recognition of fatty casts in the urine should prompt evaluation for nephrotic range proteinuria, an underlying systemic or glomerular disease, often accompanied by edema, hypoalbuminemia, and hyperlipidemia in clinical presentation. Waxy casts are highly refractile, sharp-edged, and brittle, derived from degenerated cellular casts. They suggest chronic kidney damage and are markers of chronicity and poor prognosis, indicating long-standing renal issues. Broad casts are wider than other casts and may be waxy, indicating severe damage and urine stasis in dilated tubules. Seen in advanced chronic kidney disease or end-stage renal disease, they are also known as renal failure casts. This slide provides a visual summary of the types of urinary casts, their key features, and associated pathologies. It serves as a quick reference tool for learners to review cast disease correlations, supporting both exam preparation and bedside recognition. In this slide, intact RBCs and WBCs in urine are discussed outside of casts. Non-dysmorphic RBCs suggest lower urinary tract sources like stones, trauma, or infection. Intact white blood cells in the urine suggest infection or inflammation anywhere along the urinary tract and can be seen in both upper and lower urinary tract infections, as well as in conditions like interstitial nephritis. But remember, WBC casts indicates kidney source of infection or inflammation, not lower. Now, let us take a close look at crystals. Calcium oxalate crystals appear as envelope-shaped, dumbbell-shaped, or needle-like structures, and are commonly found in calcium oxalate nephrolithiasis, the most prevalent type of kidney stone. They can form at any urine pH and are especially important in the context of ethylene glycol toxicity, where their presence alongside acute tubular necrosis and high anion gap metabolic acidosis is diagnostic. Calcium phosphate crystals appear as rosettes or elongated prisms, often with one blunt and one pointed end, and are more likely to form in alkaline urine with pH above 6.5. They are associated with calcium phosphate stones, distal renal tubular acidosis, also known as type 1 RTA, and use of carbonic anhydrase inhibitors such as acetazolamide or topiramate. They are less common than calcium oxalate stones, and they form best in alkaline environments. Uric acid crystals present as rhomboid or rosette-shaped structures and are typically seen in acidic urine with pH below 5.5. They are strongly associated with conditions that involve high cell turnover or purine metabolism, such as gout, tumor lysis syndrome, and a high purine diet. Uric acid stones are radiolucent on X-ray, a key imaging clue. Struvite crystals have a coffin-lid appearance, found in alkaline urine. Composed of magnesium, ammonium, and phosphate, they are associated with infections by urine-producing organisms. They cause large staghorn calculi, often in women with recurrent UTIs. Cystine crystals are hexagonal, colorless plates, pathognomonic for cystinuria, a hereditary disorder. Often seen in acidic urine, they are difficult to dissolve and lead to recurrent stones in young patients. A comparative table summarizes the morphology, pH association, and clinical implications of common urinary crystals. This is a key visual slide to consolidate knowledge and support quick recall for exams or clinical reasoning. This slide presents board-style questions that integrate casts and crystals with clinical scenarios. Identify disease entities based not only on microscopic findings, but also on clinical context, such as volume status and comorbid conditions. Final tips include memorizing cast and crystal disease pairs for board success. RBC casts are diagnostic of glomerulonephritis, especially in nephritic syndromes. WBC casts are linked to pyelonephritis or acute interstitial nephritis, indicating intrarenal inflammation or infection. Fatty casts, especially those with a Maltese cross appearance under polarized light, are pathognomonic for nephrotic syndrome, reflecting significant proteinuria and lipiduria. Granular or muddy brown casts signify acute tubular necrosis, whether ischemic or toxic in origin, and are among the most specific urinary findings for this condition. Waxy casts, often seen in conjunction with broad casts, point to chronic kidney disease or end-stage renal disease, signaling severe and long-standing tubular damage. Among crystals, hexagonal crystals are classic for cystinuria, a genetic disorder causing recurrent kidney stones in young patients. Envelope-shaped crystals suggest calcium oxalate stones, frequently linked to ethylene glycol poisoning. Coffin-lid-shaped crystals indicate struvite stones, often associated with urese-producing bacteria in recurrent UTIs. Urine pH also offers diagnostic clues. Acidic urine favors formation of uric acid or cystine stones, while alkaline urine promotes struvite and calcium phosphate crystal formation. This slide urges learners to internalize cast disease and crystal disease pairings, as they are not only pivotal for clinical reasoning, but are also repeatedly tested on medical board exams like USMLE and in nephrology assessments. If you learned a lot from this video, please like, share, and subscribe. I will also entertain questions and requests in the comment section. Watch out for presentation on kidney stones and management.